Hello and welcome to Second Opinion. Investigators provide perspectives on the current and future management of small cell lung cancer. I'm Dr. Misty Shields, and I'll be moderating the meeting today. This is our faculty for today's event. Dr. Anne Chiang, welcome. Dr. Apar Ganti, welcome. And Dr. Louise Paz-Ares. Here are the relevant disclosures for each of our faculty. Here is the commercial support for today's event. Research to Practice CME Planning Committee staff and reviewers have no conflicts of interest to disclose. This educational activity contains discussion of non-FDA approved uses of agents and regimens. Please refer to the official prescribing information for each of the products for their approved indications. This is one of the 14 Research to Practice event programs that is occurring in conjunction with ASCO. All are accessible in person or virtually. We have the privilege and honor to have additional faculty who have met and with Dr. Love in order to make this meeting more relevant to our participants here and online. Dr. Love has conducted video interviews with Dr. Charu Agarwal of the University of Pennsylvania and Dr. Tiziana Leal of Emory University. During these, they will be presenting cases and questions related to the topics being discussed today. Excerpts from these interviews will be shown throughout this program this evening, and our faculty will provide a second opinion. This is where we're headed today. I will be talking about first-line extensive stage small cell lung cancer management and maintenance therapy. We'll then have a program with Dr. Paz-Ares discussing the management of relapsed refractory small cell lung cancer. Dr. Chiang will then discuss the ongoing investigation and potential role of antibody-drug conjugates in small cell lung cancer. And finally, Dr. Ganti will be discussing the management of limited stage small cell lung cancer. To start us off, speaking about first-line and maintenance therapy for extensive stage small cell lung cancer, we are truly in the era of scientific revolution for small cell lung cancer. We've really seen more progress in the last 5 years than we saw in the last 4 decades preceding. Really seeing the novel biology, understanding of small cell impacting practice and outcomes for our patients with novel mechanisms of action of monoclonal antibodies with immunotherapy, antibody-drug conjugates, as well as bispecific T-cell engagers. We've seen real tangible progress for patients with small cell lung cancer, including multiple FDA approvals since 2020, as you can see with lurbinectedin, trilaciclib, tarlatamab, durvalumab, and lurbinectedin with atezolizumab and first-line maintenance therapy. And so with a plethora of options, what is the right sequence? How do we bring this to our practice and really choose the right regimen for our patients to provide the best, highest quality care? Chemoimmunotherapy became the standard of care for first-line extensive stage small cell lung cancer after the advent of this into trials with the Empower 133 study presented in 2018, as well as the Caspian study shortly thereafter in 2019. These are looking at agents with atezolizumab and durvalumab, respectively, both anti-PD-L1 therapies. And these were compared to the standard of care chemotherapy for extensive stage small cell lung cancer, which had really been in practice since 1985, beating out a multi-drug regimen, cyclophosphamide, adriamycin, and vincristine. This provided a magnitude of benefit of approximately 2 to 2.5 months for patients, and we really do see this tail of the curve for our patients with receiving chemoimmunotherapy. So does the choice of immunotherapy matter? Is there equipoise? Is there therapeutic exchangeability? Or does one regimen potentially have an advantage over another? We've seen 2 recent real-world studies investigating the role of a head-to-head comparison in these retrospective cases at single institutions, looking at the role of anti-PD-L1 therapy with either durvalumab or atezolizumab. And we saw the single institution study coming out of Moffitt Cancer Center presented 2 years ago in lung cancer, showing potentially a survival benefit for patients receiving durvalumab compared to atezolizumab. We also saw a recent study presented this year in lung cancer showing no significant difference comparing the two anti-PD-L1 agents. So are there long-term responders to immunotherapy? Absolutely, yes. We saw the 5-year overall survival data with the extension study Umbrella A, which was an extension to the Empower 133 study throughout the COVID pandemic, following patients who continued to receive atezolizumab in this extension study with a 5-year survival of 12%, an improvement from 2% historically. And when we look at the 6-year data, we're at 11%. So really, these are patients that are the tail of the curve that are benefiting, and it's meaningful for our patients to have this long-term survival. So can we intensify our maintenance? Can we add to the immunotherapy backbone that has improved outcomes for our patients with extensive stage small cell lung cancer to help more patients have better disease control and live longer with extensive stage small cell lung cancer, which is what we all are hoping for? We saw the data last year presented by Dr. Paz-Ares at ASCO 2025 with Forte, the phase 3 2-arm study looking at the role of atezolizumab in the maintenance setting, our standard of care, compared to lurbinectedin plus atezolizumab as the investigational arm. We saw the dual primary endpoints of progression-free survival and overall survival. And again, making sure that we know here that G-CSF is mandated in this maintenance phase. And there was a double screening with patients who had brain metastases that were excluded from this study. We saw a significant improvement in both progression-free survival as well as overall survival. Here you can see a PFS of 5.4 months compared to 2.1 months with a hazard ratio of 0.5. And remember, this is randomization from the time of maintenance, not from the time of starting induction chemoimmunotherapy. When we look at the subgroup analysis, we see that benefit across the board of patients with potential poor prognostic biomarkers that we sometimes see in small cell lung cancer, such as those patients with liver metastases particularly. We also saw an improvement of overall survival. Again, remembering this is from the maintenance phase. We're remembering that when we look at overall survival for chemoimmunotherapy first line, approximately 12.8 to 13 months with the addition of IO. And we're thinking about this as an additional 3.2 months from the induction chemoimmunotherapy followed by the maintenance phase. We see an overall survival here from that stratification and randomization at that time with 13.2 versus 10.6 months with a hazard ratio of 0.73. Again, looking at the subgroup analyses and really paying attention to those patients who have liver metastases at baseline. There were no major safety signals, as we know, adding an additional chemotherapy agent with the mandatory G-CSF. Those are safety signals as anticipated with potential nausea, GI upset, and myelosuppression, as we would anticipate with this agent. We also saw the data from tarlatamab, the DLL3 CD3 bispecific T-cell engager. This received FDA approval in May 16, 2024, based on the Delphi 301 phase 2 study comparing 10 milligrams and 100 milligrams doses with an objective response rate of 40% and a disease control rate of 70%. We saw a full regulatory approval in 2025, and we saw that this was following additional platinum-based therapies, as we saw with the Delphi 304 study. No surprise here, the box warnings of cytokine release syndrome and neurotoxicity with close monitoring on day 1 and day 8 with this regimen. When patients respond, typically we're seeing 90% are having response at that first scan 6 weeks in, and majority of patients having responses that are durable, lasting over 6 months. We saw the data at World Lung presented in 2025 with the data from Dr. Paulson showing the phase 1b Delphi 303 study for looking at tarlatamab in the first-line maintenance. Patients received chemoimmunotherapy with anti-PD-L1, either atezolizumab or durvalumab was allowed. Patients were allowed to switch, and there was no randomization. Patients received 10 milligram IV every 2 weeks as standard for tarlatamab. And the study was very well balanced with the majority of patients receiving this regimen with the presence of both brain metastases and liver metastases represented in the study equally. Again, as anticipated, we see CRS occurring early. We see dysgeusia, as we would anticipate with chemotherapy, as well as a BiTE therapy targeting DLL3 and CD3. And we saw that cytokine release in this maintenance setting really did occur primarily after the first or second dose. Again, no surprise here, as we know from this agent. But what was astounding was the overall survival that was reported out at World Lung 2025, really taking us all by surprise with the median OS, again, not a randomized study, but in either anti-PD-L1 agent with atezolizumab or durvalumab, with an overall survival reaching 25 or not reached in this initial phase 1b study, really catching all of our attention as this really surprising first-line maintenance study. Again, still phase 1b, still early, but more to come, I think, with this regimen. Again, we saw the progression-free survival here hovering around 5.5 months, really kind of out of proportion to that survival benefit that we're seeing. So there are several ongoing phase 3 studies with tarlatamab, drawing your attention to Delphi 305, which is a phase 3 component of this maintenance setting. Also ongoing is the phase 3 study with Delphi 312, which is looking at the role of tarlatamab in the first line, beginning with either cycle 1 or cycle 2, which chemotherapy for 1 cycle is allowed prior to enrollment on the study. I think these are going to be really exciting studies for us to see how this changes potentially our landscape for first-line and first-line maintenance. And finally, we have the privilege and pleasure of having Dr. Anne Chiang, one of the investigators here for the SWOG study, looking at PRISM with this S2409 study, a cooperative group study, looking at can we use neuroendocrine subtyping, those transcription factors that potentially small cell has a dependency on, to inform treatments in the first-line maintenance setting. An exciting study. This is actively occurring, and we hope to hear more about this readout soon. So the questions do remain. What is the IO backbone? There's no difference. Is there potentially a differential OS benefit between these two agents with lurbi and tarlatamab? How do we manage brain metastases? I think we'll find out more at this conference. And will the subtypes matter? We'll have PRISM to address this. We now will have a case with Dr. Tiziana Leal and Dr. Love.
Good evening, everyone. In our unique second opinion CME format, we enlist clinical investigators to meet with me and come up with interesting and relevant questions for the faculty to discuss. Tonight, we focus on recent developments in small cell lung cancer, and I met individually with Dr. Chiru Agarwal and Dr. Tiziana Leal, and to begin, both investigators presented patients with extensive stage disease where the IMforte trial use of maintenance lurbinectinib was a consideration. How about your 65-year-old man who presented with severe abdominal and back and lower extremity pain and was found to have extensive bone metastases, particularly in the thoracic and lumbar spine?
This patient received steroids and then was seen by neurosurgery and underwent surgical emergency treatment. He underwent T9 to 10 to T11, L2, L3 surgery with emergency bilateral posterolateral fusion. After recovery from surgery and post-op radiation, this patient was initiated on carboplatin, etoposide, atezolizumab. He tolerated treatment well and achieved a partial response after 4 cycles. Then we get to the decision about first-line maintenance. He elected to proceed with first-line maintenance therapy with atezo plus lurbinectedin with the addition of growth factor support. He tolerated the treatment well, did require dose hold and dose reduction of lurbinectedin after 4 cycles of first-line maintenance for grade 3 fatigue, but he remains on therapy and has well-controlled disease to this day. Let me know your thoughts on the IMforte data. How has this impacted your clinical decision-making with your patient at this point of first-line maintenance? Do you talk about it at the initial diagnosis, or do you wait till the completion of induction to see what kind of response your patient has? What has been your experience about having to dose hold, dose mods, and how has that gone?
think we have a lot of exciting questions to get through here. I want to make sure we have these all addressed. Louise, can you speak to how are you incorporating this strategy as with the Inforte regimen into your day-to-day practice? Do you discuss this at time of diagnosis or once you're getting up to the maintenance phase after you've completed induction therapy?
That's, I think, a very practical question, very important. So we tend to explain to the patient maybe the first day what is going to be the initial treatment. We don't like to kind of overwhelm the patient, so we typically go through what is going to be the chemo-IO part of it. We tell them that, of course, we will be doing some CT scans to see how the disease is going. When we are getting into the second or third cycle, when we have seen the initial CT scan with a response, we then say, well, after the 4 courses, we typically withdraw platinum and etoposide, and then we have now a new treatment opportunity here, and then I explain the pros and cons. Of course, that is going to be also depending a bit on the patient. If the patient is having really, for example, huge toxicity, myelosuppression, and so on, the patient is really tired, maybe I'm not that pushy on going on that part. I still would say most of my patients are at the time reasonable candidates, but I understand this is a decision that to be made between patient and physician. But importantly, I'm not overwhelmed the very first day of my clinic with induction and also more chemotherapy if you're doing well. Okay, I think that's very important. I don't know what you do.
I'd love to hear from Anne or Apar. Do you have anything different in your practice?
I'm happy. Oh, sorry, go ahead. I think that in that Inforte trial, there were about 25% of the patients attrition from induction to the randomization and maintenance. So we do have patients who are beat up by the chemotherapy, and I do have equipoise for them if they are PS2 for sure, if they're really struggling to say, okay, let's just do immunotherapy, and I think that's okay. I do say up front that we're gonna do 3 drugs initially, and that we're going to scan you and see how it goes, and then we'll drop one of those drugs. That'll be a little bit easier, or not drop one of them, but we'll switch over to a different drug. So I don't go into all of it, but I do give them the heads up that we are going to keep on going with chemotherapy, and of course that's the discussion about why and what the clinical trial was. So I think that is important to give them a heads up. Otherwise, they say, what? I thought I was done. Well, they still ask that anyway, but...
Wonderful. And Apar, there are circumstances where you're choosing your IO backbone based on what you're going to do in the maintenance setting. Do you ever say, well, I'm going to pick atezo for this patient and durvalumab for another patient? Or are you comfortable switching, or do you switch?
That's an interesting and very practical question. I generally tend not to switch because there is very limited data or almost no data on switching immunotherapy. By the same token, while I believe that atezolizumab and durvalumab are interchangeable, the Inforte trial used atezolizumab, and so if I was going to use lurbinectedin, I would use atezolizumab. No, I do not choose the initial regimen based on whether or not I think the patient would respond. Of course, practically what happens is a lot of these patients are treated in the hospital for the first cycle because they come in pretty sick. And typically when I assess them after cycle 1, depending upon how well they look, a lot of them have a significant improvement in their symptoms. And so I'm encouraged by that. And plus, if I don't have to dose delay because of cytopenias after that cycle, my preference is to use atezolizumab and maybe try lurbinectedin if feasible later on after the 4 cycles of induction chemo-IO.
Wonderful. And back to you, Anne, on what is been your experience on the tolerability of lurbinectedin in this maintenance setting in the first line? How frequently had you had to stop, hold doses, modify doses? And what's your approach to prophylactic GCSF? Has this been fairly effective in helping patients stay on therapy?
My experience has been good. Patients, we do use prophylactic G. They've already been through the EP, so their marrow has already seen chemo, and I think that's helpful. So have not really, it's been relatively well tolerated.
Very good.
Same here. I mean, if you look at the trial, the probability of getting a febrile neutropenia or a severe infection is really low, in the 1% and 3% rate. So I think it's important to give GCSF because keep things under control, to be honest. Easy to give and easy to tolerate.
Here is our second case from Dr. Chirag Agarwal.
Decisions in small cell related to the use of the combination of immunotherapy and lurbinectedin maintenance must consider the patient's age and comorbidities, but also the tumor-related complications from the disease and its effect on performance status and potential tolerance to maintenance therapy. Dr. Agarwal provides care for a 78-year-old man, a former smoker with COPD and coronary artery disease, who presented with very symptomatic extensive stage small cell cancer.
I ordered an MRI of the brain, and he has multiple brain metastases. There's significant edema. Now this guy's headaches. He's not feeling very well. We have to initiate whole brain radiation therapy before my planned cycle 1. How would you manage this? I would love to actually get into the nitty-gritties of how they initiate LURB maintenance in terms of timing. If somebody's sick enough to not get LURB at month 4, do I add it at month 6, month 8? Are there patients who should get consolidative RT following chemo IO? And if yes, how should we think about sequencing the immunotherapy and the RT? If we get through the white count issue and the myelosuppression, it's actually not that terrible to maintain people on lurbinectedin. And I have somebody who's now 6 months into lurbinectedin maintenance and doing actually really well.
Wonderful questions and a lot of things for us to discuss. So, Apar, for this patient that Dr. Agarwal is discussing, how would you proceed with this case? Would you recommend lurbinectedin maintenance to this patient or one of your patients with extensive stage small cell lung cancer and a history of brain metastases, given that they were excluded from the original trial?
So in this situation, I'm kind of a purist, and since the patients with brain metastases were excluded from the IMforte trial, I would not recommend it. Having said that, I think not including those patients in the trial was a mistake in terms of the trial design, because someone like this would have received brain radiation initially and then received chemoimmunotherapy. So by the time they reached the maintenance phase, their brain metastases were controlled and potentially resolved. And so I feel that this patient potentially could have benefited from maintenance lurbinectedin if they were in good enough shape to get it at that time. But since they were excluded from the trial, I would not recommend it in this off protocol.
Thank you so much. Anne, would you do anything different in your practice?
I would agree with that. I think, unfortunately, patients with brain mets were not included in the trial, so we don't really have data there. I mean, we certainly, I think, all treated relapsed patients with brain mets with lurbinectedin. So, and we do have that additional ability to do local therapy, but I would probably have not done that for this particular patient.
Louise, I'd love to hear your thoughts.
Okay, so what I would do is I would explain to my patient the situation. I would say those patients were not included in the trial because at the time the evidence we had was that maybe lurbinectedin was not as effective in the brain, and they didn't like to risk the trial to be negative because of that. Now we have some evidence suggesting that we don't have, I would say, robust evidence about the relevance, about the efficacy in those patients, but with that, we do not have evidence against, and that is important. I think I like my patient to know that, and depending on that, I would do. I think it's going to be very important to actually do some trials in those patients with maintenance. That is the right thing to do. But I mean, the lack of results on that setting doesn't mean the data are negative, and that is important to explain to my patient. But anyway, I think we have to do that to try to, let's say, create that evidence, and some trials are needed for sure.
Thank you so much. And, we have had patients who have really meaningful, durable responses to lurbinectedin, and if that's the right therapy for that patient, systemically, as long as you have good CNS control, it seems very reasonable. And we know that chemotherapy does have CNS penetration with our initial induction. I have patients personally that have been on lurbinectedin for over 50 cycles and doing well. And we also have our biomarker, as well as I know many others are studying it, but with potentially those are patients who are going to have durability for lurbinectedin. And in particular, in our paper, we discussed a patient who had a single brain metastasis that was developed on lurbinectedin, had radiation, and has now still no evidence of disease, 4 years later. So, I think it is a personalized decision, and I love hearing all of your thoughts and practices on how do we incorporate this for our patients. And how would you approach the initiation of lurbinectedin maintenance for a patient with potential complications related to their small cell that renders them maybe perhaps too unwell to start at the beginning of the maintenance phase? Do you ever add it back later?
As you may know, the trial at time of maintenance, at time of randomization of maintenance, you still had to have the PS of 0 to 1. And there was attrition, as I mentioned, 25%. So, if I have a patient who is PS2, we'll just do immunotherapy. I think it's fine, and I have equipoise for not giving them the lurbinectedin. I think that's fair. I think there are a number of patients who struggle with, I think the paradigm where you could do a limited number of cycles of chemotherapy and then have time to recover is important for our patient population who's going to have this disease for a long time. Would I add it later? I would not. I would wait and see. I would give them the benefit of the break, scan them, and then at time of progression, consider adding. And I think in the trial, the trial didn't answer, the IMforte trial didn't answer the question of, can you sequence it? Can you add lurbinectedin later, or do you have to do it at time of maintenance? I think there are some that say, okay, well, if we're just adding, we're treating with second-line therapy early and getting that benefit. So in the end, I think if they are too sick to get Lurby at the time of maintenance, I would just go with the immunotherapy and then give them a break. And then at time of progression, we'll talk about the different options.
Well, I think, in the trial, so 75% of the patients went to the randomization phase. Most of the patients didn't go because they progressed or because they were sick enough. So those patients that were sick, that means, are not good candidates, to be honest. So, those were patients typically with complications or progression or really through complications. So typically, I wouldn't go with those patients into the trial later on. I don't think it's worth it. The patients are not in good shape. Typically, patients are feeling better at the time of maintenance as compared to baseline. Baseline patients very often are PS2 and PS3, not in the trial, but what we see in the clinic, right? Mm-hmm. Those patients are admitted. They call you on a Friday, 3 o'clock, and then you go there and start the chemo, right? That is the typical patient with small cell cancer. It's quite sick to start with, but chemotherapy typically improves things and so on. But I think it's a reasonable way to go. If I cannot start, I maybe delay it for second line.
Apar, I would love to know your thoughts on consolidative radiotherapy after first-line chemoimmunotherapy for your patients with extensive stage. Can you briefly walk us through the data historically, and do you do this? And if so, how do you sequence it?
So if you recollect, the original trial that looked at consolidation radiation was done in the era prior to immunotherapy. And if you look at the trial itself, the benefit was not that great. In fact, the trial was negative in terms of its primary endpoint. The benefit was, it took off because there was a higher proportion of patients alive long-term compared in the group that received consolidative radiation compared to those who did not. And so the magnitude of benefit is relatively small. And with immunotherapy now taking over and showing such good benefit with just single-agent immunotherapy maintenance, my practice has been to not use consolidative radiation therapy. In fact, there have been some trials trying to look at that as well. So off protocol, I would not do it.
Luis?
Okay, so I agree. I mean, that trial was mainly negative. If you like to interpret something, I would say there was maybe some subset of patients that may potentially benefit. That would be those patients with residual disease in the chest. That is maybe 10 to 15% of the patients. So sometimes I'm doing a PET scan and so on, and those patients that are really having not much disease, I may consider, talk to the patient, pros and cons, of course, knowing that the evidence is not truly robust, and we made the decision together. It's not crazy. Maybe 5 to 10% of my patients would go that path.
And briefly, would you do the same?
I think I would wait for the trial to come out. I mean, if they are symptomatic, certainly, and have a need for palliative radiation, then absolutely. But I think that the Raptor trial will let us know whether consolidation and immunotherapy will be a positive or be recommended. So for now, I usually just avoid it.
Wonderful. Thank you. So we're moving on to our second module. Dr. Paz-Ares, will you please take the stage?
Oh, thank you. Okay. So thank you very much. And over the next few minutes, I'm going to go through the mainly couple of topics. Lurbinectidine anti-cell engagers. Those are mainly the new kids on the block over the last few years after Tuputica, I would say. And for lurbinectidine to start with, I mean, this drug is an alkylating agent, typically binds to guanine-rich regions in the DNA, and actually, by doing so, stalls RNA polymerase II, phosphorylated, so that it becomes easily degraded, ebucinated, and doing so, it induces double-strand breaks, therefore apoptosis. So this is what happened to patients. This is a phase 2 trial we have done some few years ago. You see responses in 35% of the patients, 45% in sensitive relapse, only 22% in resistant relapse. So the overall the median OS was not overwhelming, but it was about 12 months in sensitive disease. That is important to keep in mind. Then, because on a phase 1 trial, we have seen a lot of responses when combined with doxorubicin, we did a trial of doxo plus lurbinectedin as compared to topotecan, and actually, two things: didn't improve outcome, no better survival. The good thing was that doxo plus lurbe was better tolerated as compared to topotecan. Even we put a drug which was not adding anything, doxorubicin was better tolerated. Then we were looking for other combinations, and actually we have some data in the lab with irinotecan, and those are the result of the phase 1 trial. 2 out of 3 patients were responded in this small trial. And if you look at the PFS was better for patients with this drug, with this combo, as compared to the first line PFS. So better. That is not typically seen in small cell lung cancer. We did the phase 2 trial. Important responses: sensitive disease, 2/3 of the patients, 64%. Insensitive disease, responses still yet in the 25% range. And actually, there is a trial looking for what is better, topotecan or irinotecan, which could be the standard of care, or the combination of lurbe plus irino or lurbinectedin alone. This trial is really close to read. It's been recruited, and I think the follow-up should be to be delivered in very little time. The other combo we were looking into after some data in the lab suggesting the synergy between atezolizumab or PD-L1 inhibitors and lurbinectedin. We have done a small trial. You see here again responses in about 2/3 of the patients, 67%. Look at the survival in second and third line, 14 months, but of course, a small trial, only some 25 patients. Then we did the phase 2 trial. We presented that at ASCO, and again, reasonable responses, also in refractory disease, regardless the patient had or not been exposed in first line to atezo. So the data are pretty good, and actually those 2 studies are the basis for the 40 trial that we have commented some few minutes ago. The second part of the trial actually is really the game changer in that very disease, is the T-cell engagers. And the reason for a T-cell engager is because you know that small cell lung cancer is typically having a downregulation of class 1 molecules. So antigen presentation is not happening in most of the cases. This is the reason why PD-L1 inhibitors are only benefiting 10% of the patients, because if the T cell is not being activated, you never help patients with atezo or with durvalumab. So what you're doing here with a T cell engager is you're engaging the T cell, and you're engaging on the other end the small cell lung cancer by binding an antigen in the surface of the cell. The antigen on the surface of the cell in that case is DLL3, and by doing so, you're doing the immune synapses non-dependent on antigen presentation. So it's a non-canonical activation of the T cell, non-dependent on the T cell activation. By doing so, T cell is activated, proliferates, go by the blood, and is finding, I would say, tumor cells and kill them. There are a number of agents. You see them here. Most of the data are with tarlatamab, but also some other agents are pretty active. Responses, 40% of the patients in second, third, fourth line. And you see the robust data, long-term data in the phase 1 trial. Median OS is 18 months, 1.5 years. That compares with 6 or 7 months in this same population with the standard of care chemotherapy. So I would say the data are striking. Toxicity, pretty well tolerated, but half of the patients do have CRS, cytokine release syndrome. Grade 3-4 only in about 1-3%, no more than that. Some 30% of the patients are having grade 1 or 2 ICANS, those neurological complications. Then the other symptoms are not that big. We will go back to that. Responses still happen as well in the brain. You see here responses are, in patients with brain metastasis in about 50% of the patients. So that is pretty impressive. And I think it's very important in a disease where the brain is a major issue. Because of those results, there was a phase 3 trial comparing in the second-line setting Tarla versus chemo, Lurve, and Robesin or Topotecan, and you see here the results with very short follow-up. Clear improvement in OS, hazard ratio 0.6, you decrease 40% the rate of death, and also you're improving PFS as is expected. Hazard ratio 0.7. If you look at the toxicity was much higher with chemotherapy, with some exceptions. You're having particularly CRS, 50% of the cases, remember, in the tarlatamab. You have some decrease in taste, dysgeusia, and also you get some decrease of appetite. So that is mainly what happened worse with tarlatamab as compared to chemo. Then the typical chemotherapy toxicities are more frequent with chemo. If you look at a bit in detail, importantly, CRS, 50% of the patients, typically grade 1 or 2, 1 to 2% grade 3. Remember, typically happen in the initial infusions. You have to do, because of that, step dosing, 1 milligram the first time, and then you increase to the standard dose of 10 milligrams. If you're having a grade 1 or 2, the second time you're doing your drug, you're having in 24% of the patients, you're repeating CRS. In the rest of the patients, you will not have it. And actually, it's very rare to have that after the second cycle. For ICANS, you're getting that again, first and second infusion, very rarely after the third infusion, and that typically is 30% of the cases, very, very rare being more than grade 2, very rare. CRS, that typically happen at about 12 hours of the infusion, and typically solving very easily, and you have to treat it, and we will go back to it. ICANS, that typically happen 4 or 5 days later. May happen on the second day, but typically 4 days later, and it's important to say. How do we grade CRS? Well, that is very easy. Fever, grade 1. Hypotension is grade 2. Fever, you treat it only with antipyretics, maybe dexamethasone. Grade 2, hypotension, you give some fluids. You also can have some low oxygens that is recovered with low flow oxygen. Grade 3, important. The definition is hypotension that is not responding to fluids. And then you need vasopressors. Or hypoxia that is not responding to low flow oxygen. Then you need high flow. And then is grade 4, hypotension that is requiring multiple vasopressor, or you need the patient to be intubated to give high pressure oxygen. And then the treatment, of course, is logical. So the main thing about the treatment is you need dexamethasone, you need tocilizumab. You're using tocilizumab always for grade 3s and often for grade 2s. Grade 2 is a gray area because it's hypotension, and hypotension may happen because you had a bit of fever and you're on on a hypotensive drug, and then you're decreasing, but after 10 or 20, 100 or 200 mils, you're back. Or maybe it's more than that. So it's important to really analyze the type of grade 2 hypotension you're having. Importantly, maybe you like to talk to your intensive care unit at a time. ICANS. The important thing is you're actually familiar with the ICE scale, which is actually looking on orientation, naming, the capacity to follow commands, writing, and attention. And you're having here some numbers that is going to tell you if your patient is grade 1, 2, 3, or 4. Typically, grade 3 and 4 are not happening, thank goodness, and you typically have some seizures or even some clear edema, loss of strength, and so on. The good thing for that is nowadays we have data suggesting that you're not used to. Maybe you like to do it, the initial infusions hospitalize the patient, but after some time you realize that you're getting used, and if your patient is living close to the hospital, you can do it. After some observation in the hospital, the patient can go home, and you have to check him by phone calls and having him back in a couple of days or so. You don't need to really have the patient hospitalized always. But the first thing is you need to be really used to that drug. You have to have your team prepared, and you have to be alert so the patient is calling you or when it's needed. I'm done.
Thank you, Luis. So for our next video, Dr. Tiziana Leal.
The impressive outcomes observed with the bispecific antibody tarlatamab have now led this agent to be commonly used in the second-line setting for extensive stage disease, and Dr. Leal is caring for a 62-year-old woman who in 2021 presented with limited-stage small cell cancer and received concurrent chemoradiation and prophylactic whole-brain radiation therapy. 12 months later, she had disease recurrence, received carboplatin with atezolizumab and etoposide, which was followed by maintenance atezolizumab. But again, the patient had disease progression. In 2023, she was enrolled in a phase 1 trial of tarlatamab, responding well, and is still on therapy, doing very well.
This patient really benefited from tarlatamab and brings a lot of hope to our patients with small cell lung cancer and to us as clinicians treating small cell lung cancer. What has your experience been in treating patients with tarlatamab and small cell lung cancer? Thankfully, our patient had mild toxicities. As expected, they were early in the course of her treatment, and then following that, she actually did quite well. What has been your experience in implementing tarlatamab in clinical practice? How have you also helped the community docs, implement tarlatamab in their own clinical practices? Our patient had limited sites of metastatic disease, but there are concerns that patients who have bulky disease, that this is a major independent risk factor for developing cytokine release syndrome when you're using tarlatamab. There's been a lot of question about if patients have bulky disease, is it important to consider a cytotoxic chemotherapy like lurbinectedin as a bridge to cytoreduce and then sequencing that with tarlatamab? What are your thoughts on that, and what have you done?
All wonderful questions. Anne, would you kind of kick us off here? So how are you currently selecting patients for tarlatamab? What has been your experience in your practice? And what advice would you offer an oncologist maybe listening in from a community practice who's going to begin administering this for the first time?
Sure. I think tarlatamab, again, if you understand the toxicities of ICANS and CRS, and you can definitely manage it. And we typically do admit our patients for 22 hours after the first 2 doses, the week 1 milligram and the week 2 10 milligram. I think that our patients have been doing really well with this. Some of the concerns we have, or I have around a patient with tarlatamab are, do you have issues with transportation? Do you live with somebody? Is there somebody who can call on your behalf or people who can check in on you if you aren't able to call. Those are important considerations. That being said, patients have done really well with this. After the first 2 doses, we put patients they go back to clinic. And certainly I've talked to a lot of folks in our community practice and our network who send them to me for the first couple of doses. They go back after that. We also have, with selected low-risk patients, we've started a very small and very careful pilot program for outpatient administration for tarlatamab as well.
Yes. We are also doing outpatient for what we consider low-risk disease at our institution, and really those patients who are not on oxygen and have good care partner support and live within an hour of our institution. Apar, for a patient who's seeing you in clinic and they may have bulky disease with relapsed small cell lung cancer, is it necessary to employ a cytotoxic before bridging to tarlatamab? Is that something you would do in your practice or have done? What approach would you choose?
I have not. I understand the theoretical risk of increased risk of CRS with someone with high volume disease, but these patients are admitted for the first 2 doses, and so we monitor them in the hospital for about 24 hours, and I've not had any issues with worse CRS beyond 24 hours. Yes, we have to give them some acetaminophen after the first dose to decrease the fevers, and maybe steroids a couple of times, but I don't recall a single patient who's had to stay longer because of worse CRS just because they had a large volume disease when we started.
And Louise, for a patient who is not receiving lurbinectedin maintenance, where in the treatment sequence are you integrating tarlatamab? Have you been seeing meaningful responses to this agent following progression of tarlatamab? What are you choosing after tarlatamab?
Okay, that is important. So, I think in my practice, I only have tarlatamab or T-cell engagers in clinical trials. It's not approved yet in Europe. It's close to, but not quite. So we are not having the opportunity yet to use it in second line. So if my patient had been not given lurbinectedin, I tend to use lurbinectedin post-tarlatamab. Regardless, tarlatamab is given in the maintenance or tarlatamab is given. As today, if I'm balancing the amount of benefit, it looks like tarlatamab is providing more benefit. It's really dramatically changing natural history of this disease, and I think it's more likely the patient is benefited. Lurbinectedin is a good drug, but I don't think it's quite the same. I'd like to just go back one thing to the bridging with chemotherapy. I don't think we have now data suggesting we have to do it. But, there are a trial with obristamig, which is another T-cell engager from Boehringer, and they got a very interesting second-line trial, topotecan plus obristamig. They give it all together, and actually the tolerance was pretty good. CRS, 50% of the patients, similarly than if you do like single agent. And importantly, the response rate was actually 65% or so. So, I'm not saying I'm going to do it tomorrow, but it's something that maybe into the future we have to see for patients that are really sick because of the disease, not because of comorbidities. If that could be a potential patient that benefit from this combination. But of course, we don't know as yet, as today, I would say.
Thank you. And we have several audience questions that are all excellent. And the first one I'd like to ask about here is, if a patient has a borderline performance status and multiple comorbidities and is not a candidate for tarlatamab, would you save Lurby instead of doing it maintenance as second line? Luis?
So, okay. So you mean if the patient is not a good candidate for tarlatamab? I have to say, very few patients are candidates for chemo and not candidates for tarlatamab. That is true, really. So I think, chemo particularly, platinum-based chemo is not, so that is important. So, but anyway, if my patient at some point is not candidate for tarlatamab maintenance, I could do it second line, for sure.
Wonderful. I think we're on to our next video.
Dr. Agarwal also presented a patient who initially received chemoradiation therapy for limited stage disease and on progression also received chemoimmunotherapy, but shortly after that had symptomatic progression.
We said, all right, we'll do tarlatamab. And he is currently on tarlatamab and doing really well.
Any questions for the faculty?
Yeah, I want to pick their brain about observation time. As these patients are getting cycle 4, cycle 5, cycle 6, how long are patients being observed? Our patients often are just leaving. There is a recommended observation time because, after you've crossed the first 2 or 3 cycles, you're not going to really have those CRS events. So do we need to observe them for 4 to 6 hours? I don't know. That's a question. One of the most difficult AEs that we are facing with tarlatamab is dysgeusia. And how are physicians managing that? They lose weight because they don't want to eat. The big question in my mind is, should we be doing some dose holds, treatment holidays?
Such important questions. So, Apar, how are you typically approaching the monitoring situation for tarlatamab, for watching for CRS, watching for ICANS neurotoxicity? How long are you following these patients after in the infusion center?
We already talked about monitoring for CRS for the first 2 doses, admitting them overnight. And then we've generally taken the approach that we'll use the recommended monitoring time after the first 2 doses. And there are increasing data that suggest that, like Charu said, if they don't get CRS after the first 2 doses, the risk of getting CRS is much lower. And I think there are trials looking at 1 to 2 hour monitoring after cycle 3 or 4. So till those data come out, our approach has been to monitor them for 4 to 6 hours after cycle 4 and work with the patient. If it's a reliable patient who lives close by, maybe work with them to try and decrease the monitoring maybe to 2-3 hours or so. But we try to push for what's the recommended monitoring time as much as we can.
Thank you. Anne, do you do anything different in your practice?
After the first 2 doses, they typically are leaving after their infusion. Again, a lot of discussion, a lot of education. They have the number and so forth, but we've not had issues with that.
Luis?
Yeah.
Okay, I agree. So after 2 or 3 courses, the patients are running away just immediately. Actually, even for the initial 2 doses, doesn't make sense. The patient is staying for 8 hours. The reason being because the median time to fever is 12 hours or 13 hours. I understand we have done the trials of observation for 6 to 8 hours. So what I'm typically doing in our clinic is, if the patient is sick somehow, if PS 1.5, or is having comorbidities, or is living far from the hospital, or is not having a caregiver 24 hours, we prefer to admit the patient for the initial 2 infusions or 3. If the patient is living close to the hospital, half an hour or so, is having a caregiver or so, we already given the initial dose and the patient is going home. We give a call at 6 to 8 hours later. The patient is having some dexamethasone with him. So if Well, of course, we always give 8 milligrams of DEXA prophylactic, and the patient is having DEXA. So if he's having fever at 2 or 3 a.m., he's having that. And if the patient is having some other problem, it's coming to us. The main issue is that we're having a fast track in the hospital for those patients. The problem is if this patient is coming to the emergency room and a general doctor is doing a triage, he's only having fever. He's going to be seated for 3 hours, waiting to be, and that is not right. So it's very important you have a fast track to see that patient.
So important. And, for my institution, really after the first 2 doses, we are just not seeing the CRS, having treated over 50 patients personally with tarlatamab. And so with this, we really, once we get past cycle 1, day 15, we are really at a 1-hour observation for our patients. It's like a drive-through clinic. I usually joke with my patients. But we are still giving fluids and still monitoring for just a short time, and then patients know to call us if there's any issues. I want to make sure we have time to discuss the dysgeusia management here, real toxicity. Anne, can you tell us about what you're doing for patients? Do you hold treatment? How do you support them?
So this is a real problem for patients. There is sometimes very much lack of taste or salty taste. We work with, we definitely get the dietitian, nutritionist involved. There are some other things you can do. You can chew some cardamom. You can smell aromas for lemon and cloves and so forth. But I will say that I have had patients who have improved taste over 6 to 8 months. I have a patient who's had dysgeusia for probably about a year, now is on her 20th cycle of Tarla and has pretty much regained her taste. So I do not think this is an absolute permanent thing. It's still very difficult to deal with, and I think, all of I think we can probably do more in terms of researching and developing therapeutics and ways to treat this, but I think the light at the end of the tunnel is that it may improve.
Yeah, I would fully agree. Having several patients who are coming up right on 2 years since the accelerated approval in May of 2024 and on therapy and doing well. And I do agree. It seems like that nadir around maybe 8 to 12 months is the worst, and it does seem to get better if patients can weather the storm. All right, Anne, would you kick us off on the next module here with your discussion?
Great. Thanks for the opportunity to talk about ADCs in small cell. I think this is a tremendously exciting topic. And I'll just start with the general mechanism of action. You have the 3 components, which are the antibody that has that's directed against an epitope on the surface of the cancer cell. Then you have your payload, chemotherapy, and that's in yellow here. And then they're conjugated or connected by a linker that can be cleaved. So the antibody recognizes the protein on the surface of the cancer cell, is endocytosed. In the lysozyme, you have degradation, cleavage of the linker, and then you release the payload, chemotherapy, that causes DNA or microtubular damage. And then you have programmed cell death of the cancer cell, and often around in cells around that's called the bystander effect. This is just a table of a number of the agents that I'm going to talk about tonight. Again, you have different antibodies, you have slightly different payloads. The DAR, that's the drug-antibody ratio, and then you have different linkers. So we'll start with B7H3, ifinatamab deruxtecan, or IDXD. This one is probably the furthest along. It's recognizing B7H3 on the surface of the cancer cell. The payload is a topo-1 inhibitor, which is very potent. The drug-antibody ratio is 4. If you look at the ID8 Lung-01 study design, this is a phase 2 open-labeled, randomized to do two different doses. And the 12 mg per kg every 3-week dose was chosen to go to the expansion cohort. These patients had extensive stage where they had at least one prior line of platinum-based chemotherapy and had to have had 3 or less prior lines of systemic therapy. This trial did allow asymptomatic brain mets that were either treated or untreated, and the results are shown here. The waterfall plot looks really good. You can see in blue, those are the third line plus patients, third line or plus, and the red is second line. So even heavily pretreated patients had a very good response rate in the 50% range. A little bit higher, 56% for second line. These responses were rapid and durable. You can see in the swimmer's plot. And the median PFS was 4.9 months, median overall survival 10.3. The forest plot did show benefit and in patients, for example, in that platinum-resistant, so chemo-free interval of 30 to 90 days, also in patients who had prior DLL3 T-cell engager exposure. This slide is great. This is the intracranial efficacy waterfall plot. So in red, that's the patients who had brain mets with no prior RT. So you can see there are definitely responses there, and green is with prior RT. The overall response rate, intracranial, 65%, and you did have concordance between systemic and CNS objective response, about 70%. So this is the phase 2 this is the safety profile, which was manageable. You saw the highest side effects you saw were nausea, cytopenias, decreased appetite, pretty well tolerated. Of course, we are worried about ILD with ADCs. And in this case, the adjudicated treatment-related ILD pneumonitis rate was 12.4%. 8% were grade 1 or 2, 3% grade 3, and there was 1.5% or 2 patients who had grade 5 events. In the ongoing phase 3 trial, in December, they actually put a voluntary clinical hold due to higher incidence of the grade 5 ILD, the fatal events. But this was lifted in January, and they implemented additional strategies for mitigation, including stricter trial enrollment criteria, more frequent review, and additional training for investigators and staff. So very exciting. This is currently under FDA review. The PDUFA date is October 2026. So if approved, IDXD would be a first-in-class B7-H3 directed ADC for these patients. I suspect that will happen. The ID8 Lung 02 is a phase 3 study of IDXD in relapsed disease, randomizing patients to IDXD at the 12 milligram per kilogram dose versus topotecan and rubicin or lurbi. Okay, moving on to the TROP2 directed ADC sacituzumab govitecan. The payload is SN38, which is more potent than its parent compound we know as irinotecan, a topo-1 inhibitor. The linker is pH-sensitive, hydrolyzable. The phase 2 TROPICS-03 was a basket trial that included lots of different tumors. There were 43 patients who had extensive stage small cell that had progressed after first-line chemo-IO, and the overall response rate was 42%, median duration of response 4.73. There's the waterfall plot, the duration of response is over there. And the median PFS was 4.4 months, median OS 13.6, and manageable safety profile. These are all of the treatment emergent adverse events that were that occurred in 10% or greater of the patients. Did not include ILD that 10% or greater. So. Well tolerated. We know this drug from breast cancer and very manageable. So the sacituzumab was granted FDA breakthrough therapy designation based on the results of the phase 2 TROPICS-03. This is the ongoing phase 3 EVOKE small cell 04 trial, which randomizes patients to SASI versus topo or amrubicin in Japan. Okay, moving on to the new and improved DLL3 after Rovati. This is the ZL1310 ADC. DLL3, very important target in small cell, this is a camptothecin derivative-based payload with this T-malin tumor microenvironment activatable linker payload platform. The drug antibody ratio here is 8, and very potent bystander killing mediated by the topo-1 inhibitor payload. This is the phase 1 trial. There's about 115 patients dosed across dose escalation and expansion. 102 patients had at least one post-baseline scan for response assessment. Again, it did allow asymptomatic brain mets, treated or untreated. And here's a waterfall plot. Beautiful. Actually, across all of those different doses, those are the different colors. The asterisks over there are patients with brain mets. So really, really nice. Best overall response rate of about 50% in those patients at the 1.6 mg per kg dose with that were in second line, but almost 70% response rate. And interestingly, about 40% response rate in patients who had either prior Tarla or prior DLL3 targeted T-cell engagers. So that's important thinking about sequencing. Okay, then there's AbbVie 706 as 6 targeting ADC conjugated to a topo-1 inhibitor payload. The drug antibody ratio 6, and also very potent bystander killing. This data was presented by Lauren Byers at World Lung. Overall response rate 56.1%. Interesting, if those patients were in second line, only one line of prior treatment, that response rate was up to 80%. Also very active in brain metastases patients. So based on this, AbbVie went straight to the Cez-Anne phase 2 trial, which randomizes first-line patients to this ADC plus immunotherapy versus standard of care. So let me just repeat that. That's a fully platinum-free option for these patients, first line versus standard of care platinum doublet plus immunotherapy. So super exciting, really paradigm-changing potentially for our patients. I'll just end with a few questions about ADCs in the future. Will ADCs be approved in the near future? I think that's likely to be true with IDXD and likely also SASI. What is the role of ADCs in first-line or maintenance therapy, either in combination with chemotherapy or actually replacing that platinum doublet? And I think that's really interesting. We're going to have to learn about mechanisms of resistance to ADCs. Is it the payload, or is it resistance to the decreased downregulation of the target? And that's really going to inform what the ideal sequencing of these therapies are. And I'll stop there. Thank you.
Thank you so much, Anne. Let's have our first case.
In non-small cell lung cancer, there are several approved antibody-drug conjugates, and Dr. Leal is curious about how you see the future of these agents in small cell lung cancer.
ADCs are an area of active investigation in small cell lung cancer. We've got some really great targets for ADC development that are in different phases of development. So we have TROP2, we have B7H3, SCZ6, as well as DLL3 targeting ADCs. We have some exciting data for IDXD, which is a B7H3 directed ADC for patients. It has actually received FDA granted breakthrough therapy designation. And so we are seeing that this agent has high response rates, CNS activity, and manageable toxicity profile. What are your thoughts on ADCs and where will they fit into the treatment paradigm for patients with small cell lung cancer? Which targets are you most excited about? And how do you see this happening over the next few years? DLL3 as a target for ADC is still an active area of investigation. We have several in development. How will we sequence DLL3 ADCs if they do come into development, into clinical practice with agents like tarlatamab or other T-cell engagers as well? What is the best way to target DLL3? Is it a T-cell engager? Is it a CAR T or an ADC?
Wonderful. A lot of really important questions to get through here. And so, Louise, given available research, findings, and your own clinical experience, which is vast, would you like to have access to IDXT or Imfintamab deruxtecan today? And if so, where would you sequence it?
Well, I think the data Anne just mentioned are pretty relevant, and I think they are going to help us in our practice. Today, I see those agents mainly as a good treatment for the relapse setting. So typically, if in the future I can use chemo IO as an induction, and maybe I could use, depending on the availability, maintenance treatment with tarla or with lurbinectedin. I may use at a post-tarla setting, I would tend to use this drug. If I have not used lurbinectedin, I could somehow balance the opportunities to use these ADCs or lurbinectedin as a treatment of the relapse. Of course, it's going to depend on how is the patient, the probability, if the patient has some pneumonitis and things like that, or if the lung function is not very good. But those would be the ways I will do it, I would say.
Wonderful. Apar, would you do anything different when you're sequencing this agent? Let's say if it does get FDA approved?
No, I would agree with what Louise said. The one thing that we have to be careful about is for patients who've had radiation, any evidence of pneumonitis or bad lung function to begin with, I would be very careful about using this drug. But otherwise, I think the data are pretty compelling, at least what we have right now. So if this drug was approved today, I probably would use it prior to Lurbi in the right patient. But if I had concerns about the patient tolerability, especially in regards to pneumonitis, I probably would stay away from it.
Thank you. Anne, given its availability in breast cancer, are there circumstances you would attempt to access sacituzumab govitecan for a patient with small cell today? And are you optimistic that we will be using this agent soon?
I treated some of the patients on clinical trial with SASI, and they did really well. They tolerated it really well, and so I think that would be a great option for our patients. I haven't tried to access it yet, even though it is available. Anticipating insurance might not reimburse it, but I think that it would be great to have IDXT or SASI available to our patients as another option, especially for patients with brain mets, because it's very nice intracranial response there.
Yeah. So, personally, I have grabbed for sacituzumab post-tarlatamab setting, permitting that there's no trials and no other reasonable options for patients. So treated about 8 or 10 patients so far with it, and it does seem that you have good responses both systemically and intracranially, which is important in this patient population. Apar, can you tell us, with IDXD relative to the other ADCs, right? Trastuzumab deruxtecan, datopotamab deruxtecan, is this risk of ILD increased because of small cell, because of potentially lung fibrosis or other comorbidities? If potentially there's a history of tobacco use, and how would you monitor for ILD if you were using this agent?
I think the risk of pneumonitis with IDXT is similar to the other ADCs in lung cancer. I mean, having said that, I've used trastuzumab deruxtecan in HER2-positive parotid gland cancers with almost no side effects. I've used Dato-DXd in patients with EGFR mutant lung cancer with minimal side effects. So I think it has to do with the radiation and the relatively marginal lung function of these patients. So my approach for these patients, regardless of which ADC I'm using, is to be very careful about their history before starting, and then monitoring their shortness of breath quite closely. At the first sign of shortness of breath, I would get a CT scan to see if this is related to pneumonitis or something else. And if it is related to pneumonitis, or if the scan shows evidence of possible pneumonitis, I would stop it and potentially start steroids in these patients. So I would be very proactive in managing these patients for ILD.
Thank you. And Louise, if you had all these agents in your clinic and your toolbox to go grab, how do you envision sequencing them as a physician scientist, as a trialist? They all have topoisomerase 1 inhibitor payloads. How do we approach this for our patients?
Actually, it's a pretty good question. I think we got really, that there are like clinical data on 19 ADCs in lung cancer, in small cell lung cancer. 18 of them are using topo-1 inhibitor payloads. Just one case with monomethyl E. Of course, topo-1 inhibitors are very effective in small cell lung cancer, are better. I'm not sure we are going to be able to go from one to the other topo-1 inhibitor. Indeed, if you look at the activity of those ADCs, it's much better if the patient had not been pre-exposed to topo-1 inhibitors. So, I'm not saying it's going to be a full CRO resistance, but I think we need to start testing some other payloads, some other type of agents, If not, it's going to be somehow limited strategy, I would say.
Thank you for highlighting that. And we have several questions from the audience, and really, honestly, fabulous questions. So thank you, and keep rolling them in. So we have a few questions clarifying these ADCs and some toxicities, and highlighting that. And one question was asking about experience with sacituzumab govitecan. I think, Anne, you highlighted this as well. I'd love to highlight this. So I think, the two main toxicities, as we saw from the TROPICS study, were myelosuppression as well as GI toxicity, with diarrhea being the highest AE, right around 60%. So I do, for my patients, follow the PRIME study. So I'm giving prophylactic Imodium on those days 2 through 4 and 9 through 11, as well as just mandatory G-CSF on that day 9, either on body or an injection in the infusion clinic. So I think that has made it very manageable, but closely monitoring patients, making sure that if they need fluids to prevent any dehydration, you're doing so, and closely watching the counts. And on your experience on patients with IDXT that have been potentially on study, or the panel, if anyone wants to weigh in, can you weigh on any other additional toxicities you've seen and how you've managed that or approached it other than ILD?
I haven't had that clinical trial open, so I can't really speak to it. But from the data, it really is myelosuppression, some nausea, some general fatigue, and of course the ILD. I don't know if any of Luis or Apar.
I think it's very much myelosuppression and, as you said, general GI tox, some diarrhea, some nausea, vomiting, and so on. But myelosuppression, apart from ILD, is the dominant toxicity, as expected. Yeah.
And we have ID8 Longo 2 open, and we've not had too many other problems with IDXT. The myelosuppression is still fairly manageable, so not had any problems with it.
Wonderful. And one more quick question from the audience. Again, excellent questions. Have any trials shown potentially these resistance to tarlatamab? And you may want to take this one, correlating with efficacy to ADCs targeting DLL3 down the line?
So great question. So again, we don't know the mechanisms of resistance for ADCs, and we don't know the mechanisms of resistance so far for Tarla. I mean, we've done, and other folks have also done, looking at progression biopsies, and you can see some downregulation of target, but that doesn't necessarily mean that they're not going to respond to other DLL3 therapies. So I think, it's an active area of discussion. I don't know if either of you want to add to that.
I fully agree with you. So, the data we have about the mechanisms of resistance are pretty scarce. What is true is that median PFS to tarlatamab in the second-line setting is about 4.5 months, and patients are going to be alive for 18 to 20 months. That means you're having 15 months to give some more therapy. So you need other drugs. Of course, ADCs are going to be great drugs, and many others. So I think we need a treatment opportunity for those patients.
Yeah. I think we have our next case, Dr. Agarwal.
On Friday night, our CME group held a symposium on EGFR mutant non-small cell lung cancer, and Dr. Agarwal is following a 52-year-old man with a related small cell issue.
Run-of-the-mill EGFR mutant, never smoker, extensive bony metastatic disease at presentation, didn't really have a lot of visceral disease. This was pre-FLAURA2. We treated him with osimertinib, actually did quite well for about 2.5 years, progressed, added chemotherapy, and osimertinib, did well for a while, progressed again, and biopsied still adenocarcinoma, gave him amivantamab and lazertinib, did well for a while, and then progressed. And then when we actually biopsied him, he ended up having a small cell transformation. And now he has extensive disease burden. I think he has more than 50 liver metastases. He has brain metastases. He has widespread progression of his bony mets, requiring multiple rounds of palliative radiation. And I gave him carboplatin etoposide. I continued the osimertinib. Had a response at 4 cycles, but then lost that response really quickly. So he's on lurbinectedin right now. The question is, what do I do next? I think I'm going to go to tarlatamab. Would you use tarlatamab?
So this is a very important and fascinating and very unmet need for our patients who are impacted by transformed small cell lung cancer. And this is a patient that's on lurbinectedin. We don't know if they've progressed or not, but what would you go for next in this patient?
I agree that Tarla would be worthwhile to test. We do sometimes do DLL3 staining in our patients to sort of support that approach, whether they're LC-NEC or something else. I think they're anecdotally, I've treated a couple of patients like this, and they have not particularly done well. I think these patients overall prognostically aren't doing so well. But I think for this patient, I would try Tarla next.
Apar?
I would agree with that, but one thing I'd like to caution is I would biopsy it before starting on Tarla to make sure that this is a small cell relapse and not a retransformation back to the original adenocarcinoma. So with these patients, it's important because they can have histology switching, and so if they progress on a small cell regimen, I would biopsy to make sure that it is indeed the small cell that is relapsing.
Such a key point. So really, it highlights the heterogeneity that we see at transformation. Not all cells are transforming. So you may still have that non-small cell clone that you still need to suppress. Louise, anything different?
No. So, I have also isolated cases. During one of the trials, I have treated 2 patients with transformed small cell lung cancer coming from an EGFR mutant adeno. One of the patients responded for about 13 months. The other patient didn't do well at all. Truly, small cell lung cancer from transformed EGFR mutant is typically doing worse as compared to the native small cell. Is doing worse on chemo IO, on Lurve, whatever. So, the data we have is not pretty good. There is at least one phase 2 trial in that patient population in Korea. Dr. Anne is doing that. So I think it's going to be important to get those data. But, honestly, we do not have much opportunities post chemo in these patients. So if I would have the opportunity, maybe I would try it.
And who here continues the EGFR TKI at transformation? Everybody? Yeah. And so when we're thinking about EGFR transformed small cell, when are we thinking about immunotherapy? Are we continuing the immunotherapy at all? And what are we thinking about any other agents like ADCs? Apar?
I've not typically used immunotherapy in these patients, even with transformation. Like Louis said, these patients don't do very well, and I'm not sure they respond to immunotherapy as well as the de novo small cells do. As far as other ADCs are concerned, I think it's worth a shot because, again, these patients don't do very well with pretty much anything. So once they progress on their osimertinib, platinum pemetrexed, carboplatin, I'm willing to try pretty much anything that potentially could work, although I'm not convinced that IO is the right answer there.
Thank you. Yeah. Anything else?
These are typically young patients, so if they have the performance status, I have at some point tried chemo IO together. Again, not necessarily with tremendously long progression-free periods, so unfortunately.
Thank you. Apar, do you want to kick us off to our last module, management of limited stage small cell lung cancer?
Good evening, everyone. It's my privilege to talk about the management of limited stage small cell lung cancer, the one group of patients that we can actually potentially still try to cure. So small cell lung cancer, I know this is the last talk, but I thought I'd give a small introduction about small cell lung cancer. It's a neuroendocrine tumor, as you all know, makes up about 15% of all lung cancer cases, equal male to female ratio. The incidence is decreasing overall because of decreased smoking habits in the US, but unfortunately it seems to be increasing in women. It is, if you take it by itself, it is the 5th leading cause of US cancer deaths and makes up about 35,000 new cases every year. It's almost exclusively seen with smoking history, with the few exceptions that we just discussed. From where I come from, one of my practices is within the VA system, and unfortunately it's highly common in the veteran population. If you look at never smokers, it makes up about 3% of lung cancer in women, almost none in men. As we've discussed, these cancers are highly responsive to chemotherapy and radiation, but relapses are almost universal, which leads to a 5-year survival of around 8% in all patients. And if you look at limited stage disease, that number goes up to about 13%. Again, these are slightly dated numbers, but with the newer addition of durvalumab, that numbers might change. We'll see. So staging workup, everyone gets a CT of the chest, abdomen, and pelvis, a brain MRI, and a PET scan. So the TNM staging is what's routinely recommended, but from a practical purpose, we use the VA lung cancer staging system, which divides it into limited stage and extensive stage. Anything that you can radiate within one portal is limited stage. Anything else is extensive stage. Over the last 5 to 10 years, there's been this increased identification, potentially due to lung cancer screening, of these really early stage small cell lung cancers, T1, T2, N0, M0. And typically they make up about 5 to 7% of all small cell lung cancers. And the reason I bring that up is there is a potential role for surgery in these patients if they are surgical candidates. But otherwise, in general, patients with limited stage disease are treated with chemotherapy and thoracic radiation with the goal of curing them. The chemotherapy backbone is platinum etoposide. That hasn't changed for the past 30 plus years. Unfortunately, cisplatin etoposide was shown to be superior in terms of toxicity when compared to the old standard of CAV, not necessarily an improvement in efficacy. But since 1992, platinum etoposide has been the backbone, chemotherapy backbone for treatment of these patients within the US. So if you look at the recent trials that looked at, the question that was being answered was radiation, but I think these trials provide an important insight into how poorly these patients do. CALGB 30610 was a study looking at once-a-day radiation to twice-a-day radiation. There was a third arm that looked at a concomitant boost, but at the first interim analysis, that arm was stopped for futility reasons. And so the trial continued to enroll patients randomized to either 45 gray given twice a day or 70 gray given once a day. And the radiation was started either with the first or the second cycle. Patients got 4 cycles of chemotherapy total overall. And the primary endpoint was overall survival. As you can see in this here, both arms, there was no difference in overall survival, but the important thing is the median survival in these patients was just about 2.5 years. So clearly we need better treatments for this potentially curable group of patients. CONVERT was a trial similarly conducted in Europe that randomized patients to 45 gray given twice a day or 66 gray given once a day, starting on cycle 1, day 22 of chemotherapy. In this trial, patients could get 4 to 6 cycles of cisplatin and etoposide. And again, like CALGB 30610, the primary endpoint was overall survival. And again, if you look here, there was no difference between the two arms. The BID arm did slightly better in this study, even numerically, even though this was not statistically significant. But the key point here is, even with what we consider our best treatment, the median overall survival was only about 2.5 years. Which leads us to, is there something that we can do better in this population? As we all know, small cell lung cancer has one of the highest tumor mutation burdens in all cancers. And so it begs to reason that immunotherapy may be a good option for these patients. And clearly we know from the extensive stage data that immunotherapy has a role in these patients with both the Empower 133 and the Caspian studies. These trials have been, Misty went over these trials earlier, so I won't belabor this. This led to the Adriatic study in limited stage small cell lung cancer, where patients with stages 1 to 3 with good performance status ECOG 0 or 1 who had not progressed after initial chemoradiation were randomized to either durvalumab or placebo. And there was a third arm, durvalumab plus tremelimumab, which has not been reported yet. There were 2 primary endpoints for the comparison between durvalumab and placebo, both overall survival and progression-free survival by a blinded independent central review. Key secondary endpoints were the comparison between the combination of durvalumab and tremelimumab with placebo, and overall survival, and again, PFS by blinded independent central review. Other secondary endpoints were landmark OS and PFS and safety. What this trial showed was that there was significant improvement in overall survival with the addition of maintenance durvalumab for 2 years compared to placebo, with an improvement of median overall survival from 33.4 months in the placebo group to an unprecedented 55.9 months in the durvalumab group, the hazard ratio of 0.73, a p-value that was highly statistically significant. If you look here, almost all groups benefited from maintenance durvalumab. Looking at PFS, again, you can see that there was a significant improvement in PFS with durvalumab, 16.6 months compared to 9.2 months with placebo. Again, if you look here, landmark PFS was also improved significantly with durvalumab. Similar to overall survival, the PFS forest plot shows that almost all groups benefited from maintenance durvalumab, regardless of age, gender, race, what platinum they got, whether they got prior once-a-day radiation or twice-a-day radiation, and regardless of what kind of response they got to the chemoradiation therapy. Safety-wise, side effects were as you would expect with durvalumab. Radiation pneumonitis or pneumonitis, you could not differentiate between the two, but that was only about 40% with durvalumab. Grade 3-4 radiation pneumonitis or pneumonitis as they in the study was only about 3%. Placebo, the pneumonitis rate was about 30% with grade 3 to 4 pneumonitis of around 2.5%. Drug discontinuation rate was about 11% with durvalumab. And immune side effects were higher as expected, with the most common being hypothyroid events and immune-related pneumonitis. The unmet needs with Adriatic, even though this is a very positive study, all of these patients received concurrent chemoradiation. In practice, we know that there are a lot of patients who cannot tolerate concurrent chemoradiation, and therefore they get sequential chemoradiation. We don't know if durvalumab is beneficial for those patients. And Adriatic did not allow patients with PS2. Again, in clinical practice, we see a lot of patients with that, which leads to this Alboran study, which is being conducted in Spain to assess the safety and efficacy of durvalumab in a real-world-like limited-stage small cell lung cancer population. The key differences between this and Adriatic are that this study allows patients with ECOG-2 and allows patients with concurrent or sequential chemoradiation and either once-a-day or twice-a-day radiation without progression. Exclusion criteria for this study are mixed, limited, small cell, non-small cell, patients with grade 2 or greater pneumonitis, and history of organ transplantation or autoimmune disorders. We've talked about tarlatamab, so I won't go into the details, but it is a key agent that is currently being studied. We all just listened to the Delphi 304 results, which showed that tarlatamab was superior to chemotherapy in a phase 3 study. This agent is being studied in the limited stage setting in this Delphi 306 trial, which is a randomized double-blind placebo-controlled study comparing tarlatamab to placebo in patients with limited stage small cell lung cancer after completion of chemoradiation. The sample size is about 400 patients. The primary objective is progression-free survival based on blinded independent central review and overall survival. Key secondary endpoints are investigator-assessed PFS, complete response rate, time to progression, and treatment-emergent adverse events. The intervention is tarlatamab or placebo given on days 1, 8, and 15 of cycle 1, and then every 2 weeks, like you would give tarlatamab. So these are the key inclusion-exclusion criteria. Concurrent chemoradiation, no evidence of progression after chemoradiation, good performance status, adequate organ function. Transformed small cell lung cancer are excluded. Patients with ILD, active infection, other malignancies, solid organ transplantation, thrombosis, and patients who received sequential chemotherapy and radiation are not eligible for this trial. Neither are patients treated with a DLL3 inhibitor. So in conclusion, the standard of care today for limited stage disease is concurrent chemoradiation followed by maintenance durvalumab. And there are ongoing studies with tarlatamab in this area, so stay tuned. Thank you.
Thank you so much, Apar. Let's get to our first case.
Dr. Leal is caring for a 77-year-old woman who presented with a 2-month history of recurrent falls, blurred vision, lightheadedness, and proximal weakness. The patient was found to have limited stage small cell cancer of the lung, and a paraneoplastic panel revealed abnormal PQ-type VGCC antibodies, which created a dilemma in terms of the use of immunotherapy.
We know that LEMS, or Lambert-Eaton myasthenic syndrome, is a rare disorder. There's always been concern that if somebody has a neurologic paraneoplastic syndrome, because this is already indicating autoimmunity, that if you add immunotherapy or agents that activate the immune system, you can generate a flare and decompensate this person neurologically, which can be devastating. Most of the trials that have investigated immunotherapy have excluded patients with paraneoplastic syndromes. How have you managed patients that are in your clinic with well-compensated paraneoplastic syndromes like this patient, and what has your experience been?
This is an area that is, really important for our patients who have these paraneoplastic syndromes. Really mentioning here this Lambert-Eaton myasthenia syndrome. I think this is rare, but we, do see these patients in our clinic or sometimes even in the ICU. Louise, what would you recommend for this patient? Very much so. We sometimes see these paraneoplastic syndromes well before we ever see something on scan, so they're more likely to be limited stage. Are you comfortable with giving immunotherapy in this setting?
So, I think the evidence here is not very robust either, to be honest. So we know some of those patients are really the patients that are doing pretty well, even with chemotherapy, pretty well in terms of disease control. Unfortunately, not always the paraneoplastic syndrome goes so well. So I tend to have a conversation with the patients, to be honest. So if the patient is really bad control, particularly myasthenia or whatever, maybe I tend to start therapy without, and maybe for the second cycle or later, we start discussing on this. But I'm not either against from the very beginning, to be honest. So I would say at the end, if my patient is having a limbic encephalitis, that could be the typical case. I'm not for immunotherapy. But for the others, I tend to see. And in fact, for example, my myasthenia, in my experience, and there are a group from Lyon that somehow compile some data on that. Those patients tend to do pretty well or reasonably well with immunotherapy as well.
And anything you're doing different in your practice if you have a patient with LEMS?
Well, I think for LEMS, there's another option for them, amifamprimine. It's an antibody that blocks the voltage-gated potassium channel, and if you block that, you can increase action potential, increase calcium influx and acetylcholine release, and actually that can reduce the weakness that they have. So that is something that was recently added to the NCCN guidelines. I think most folks would need a neurology consult for that. That's not something that we typically manage as oncologists, so I would definitely get neuro involved in that.
Yeah.
I would tend to agree with Luis that for a paraneoplastic syndrome, something limbic, encephalitis, something that you don't want to mess with that. MS, I have never used immunotherapy, but depending on what it is, you might consider it. But again, it's a benefit-risk ratio.
Apar, based on what we know from our NCCN guidelines, which you chair, anything specific to the management, diagnosis, detection you'd like to add?
I think it's important to keep a very high threshold of suspicion for these paraneoplastic syndromes, and I would not hesitate to consult the appropriate specialty at the first sign, because clearly, as oncologists, we are very ill-equipped to handle some of these endocrine and neurologic side effects. So I would not hesitate to reach out to my neurology or endocrine colleagues and say, I need some help over here. And I think the sooner you do that, the better it is. The one thing that I would strongly recommend, is picking up the phone and calling the neurologist or the endocrinologist and telling them the gravity of the situation. Because practically, if you look at it, most of their clinics are booked out and you won't get an appointment for 3-4 months. So if you call them, that usually tends to get them excited about something like this and see the patient sooner.
Absolutely agree. And I have patients in my clinic with LEMS and have tried this medication and seems to have helped their Lambert-Eaton related symptoms as well as treating the disease is the most important as well. Let's go to our next case.
The final case, presented by Dr. Agarwal, is an uncommon and challenging dilemma in the management of small cell lung cancer.
This lovely woman who I'm struggling with what to do, she's 82, fantastic physical shape, amazing, walks more than 5 miles a day, has a very, very, very tiny lung nodule that is being followed for several years, and remote smoker. And finally, it becomes big enough to do a bronchoscopy on. And this tiny little lung nodule is like 1.2 centimeters. And we do a bronchoscopy and it comes back as small cell. And she has an 11L lymph node that is positive for small cell. Nothing else, right? She has no other evidence of disease. So I give her platinum with radiation. She does great, fantastic, in fact. And I put her on durvalumab, and she develops horrendous pneumonitis. She's oxygen dependent, she's on steroids, she's gained all this weight. Mind you, this is a woman who was playing golf 3 times a week. So now we have her off steroids. She is off oxygen. She's doing really well. We've seen maybe a handful of these over the years, and I think the way that we have managed it has been giving them adjuvant platinum etoposide. And, the question is out there, do you give them a year or 2 of immunotherapy? I don't know. I think that would be a really good question. What about radiation? Do they need radiation in the absence of any high-risk features?
All really great questions. So, Apar, would you mind answering this for me? So what would you have recommended in Dr. Agarwal's case of a patient who had localized 11L positive disease? Do you offer patients adjuvant immunotherapy, and how long? Would you have omitted the radiation in her case?
There is an ongoing trial that Jacob Sands is running to answer the specific question about adjuvant immunotherapy. In that study, patients with resected small cell lung cancer after 4 cycles of chemotherapy are given durvalumab. It's a single-arm study. Today, without those data, I would not offer adjuvant immunotherapy. And as far as radiation therapy is concerned, we don't have good data on what to do with N1 disease. Most radiation oncologists would recommend radiation with N2, but I think with N1 disease, at least my preference is we would discuss that at our tumor board. And from my experience talking to my radiation oncologists, they've been relatively reluctant to offer adjuvant radiation therapy for N1 disease. We would do 4 cycles of chemotherapy, but I probably would do 4 cycles of chemotherapy and leave it at that.
Thank you. Anne, would you do anything different in this patient's case?
No, I think for resected small cell, give adjuvant chemotherapy, put them on trial or just watch them. And the radiation, I guess I would, the key for these patients is a really important multidisciplinary tumor board discussion. That's key. But in this case, I don't think they'll get additional radiation.
Luis, anything different you do in your practice?
So the way we do it is if the patient is resected because of diagnosis and therapeutic at the same time measure, then we typically, if the patient is N0 or N1, we do not give radiation. And actually, I mean, it's in our multidisciplinary team guideline and it's on the ESMO guidelines. And we give only radiation, chemotherapy, 4 courses. That is on the guidelines. If the patient is having N2, is giving chemoradiation. This is based on observational study. It's not on a randomized trial, but the data are strong enough. Today, after Adriatic, if I'm doing chemo, I'm doing chemo-IL. And, I don't think we are going to have a randomized trial in this setting. And if the local treatment is radiation, then we show that Adriatic is helping. I tend to discuss with my patient. I say, we don't have the full evidence, but we have the evidence that after another type of local treatment, we should give immunotherapy. So I have maybe over the last 2 years, 2 or 3 cases, and I have given to them chemo-IO. So I do give 4 courses of chemo, and then start from day 1 immuno, and then I tend to give it for 2 years. But I understand this is to be discussed with the patient. There are no data out there.
Thank you for highlighting all of those important points. And for our patients with more typical presentations, limited stage, node positive, right, maybe larger size or not resectable, are you always following an Adriatic regimen, or are there any patients we haven't highlighted here that you would avoid or omit the immunotherapy? Apar?
So, unless the patient has bad pneumonitis from the radiation or has otherwise compromised lung function, I would, or others obvious contraindications for checkpoint inhibitors, I would try to get 2 years of durvalumab in the majority of those patients. I can't think of anyone who I would explicitly exclude unless they have bad pneumonitis after the radiation.
Yeah.
Thank you. I know that we're nearing close to time here, and this has been a lovely program. I do have a large number of audience questions. I'd like to just ask maybe one, just quickly, 10-second answer for me if you can. A patient who has de novo small cell lung cancer has an NGS report, EGFR, L858R. Are you adding an EGFR therapy, Louise?
Yeah.
Okay. Patient presenting with SVC syndrome and extensive stage, do you give RT, or do you do chemo, or both?
Chemo.
Right away? Chemotherapy. Mm-hmm. Okay. Apar, a patient who has grade 2 or 3 ICI pneumonitis, do you ever re-challenge?
No.
All right, Louise, any rationale for combining a DLL3 ADC and a DLL3 TCE?
There is the same rationale to combine it that for not combining it. We don't know. There are some trials ongoing, but I'm not sure it's the best idea or not.
Okay. A few more rapid fire here. Patient has limited stage, gets chemo RT, progresses 8 months later. Are you going back to chemo, or are you going to Lurby? What are you going to next for relapse limited stage?
Is it 3 months?
8 months.
8 months. Okay, 8 months is in the middle, right? So, if that would have been 1 year, I would go chemo. If it's 8 months, maybe Lurbe. But anyway, if I'm having Tarla, I would do Tarla in any case.
Okay, and if they haven't seen immunotherapy?
I could do, I could do Tarla for sure, and I could do Tarla IO.
Okay.
So the reason there are no data with Tarla IO outside of the maintenance setting, but it makes a lot of sense. You look at all the T-cell engagers in lymphoma, myeloma, whatever, one of the typical mechanisms of resistance is turning the microenvironment to more immunosuppressive. So it makes a lot of sense. And actually, the data in the maintenance setting suggests that IO may help T-cell engagers to work.
Fabulous. We're at the top of the hour, the top of our program. Thank you to all of our wonderful faculty for all of your expertise and really helping take research to practice. Thank you for tuning in, and thank you for everyone who attended here in the room and online. And with that, we'll conclude. Thank you so much.
Thank you.
Thank you.